I'm presenting a post hoc analysis from the SUSTAIN-7 trial, which evaluated semaglutide versus dulaglutide in patients with type 2 diabetes. As you recall, this is the original design of the SUSTAIN-7 study, which evaluated 2 doses of semaglutide, 0.5 and 1 milligram once a week, compared to dulaglutide, 0.75 and 1.5 milligrams once a week. Low dose versus low dose, high dose versus high dose. In this post hoc analysis, we specifically specified and divided the groups by age. Older adults were considered age 65 and older, and non-elderly were less than the age of 65. Here's the baseline characteristics, and what you'll notice first off is we have pretty decent representation of the numbers, about 60 to 70 in the older groups, 200 plus in the non-elderly groups. The age was about 69 in the older groups, 50 in the younger groups. Diabetes duration was longer in the older groups, about 10 years, versus about 6 years in the younger groups. Baseline A1C, 8%, BMI about 32. This was not your frail elderly. These were your robust, obese, type 2 diabetic elderly, older patients. And what were the main findings? So we looked at it in a couple different ways. One was older versus non-older within each treatment arm, so hatched versus solid. And what you see in terms of the patterns is similar A1C reductions between the hatched and solid in each of the individual arms. So older adults were as responsive to the therapies as were the non-older adults. Now, in terms of the comparison of semaglutide versus dulaglutide, general patterns persisted that were seen in the primary study, and that is a greater A1C reduction with semaglutide versus dulaglutide at the lower dose in both older and non-older individuals. At the high dose, there was a similar A1C reduction in the older adults and then a greater one in the non-older adults. What about changes in body weight? In general, numerically speaking, looking at the hatched representing the older adults, you see a tiny numerically greater weight loss in the older adults, but not significantly so. And then the patterns of weight loss similar to the primary trial, where there was greater weight loss with either dose of semaglutide compared to either dose of dulaglutide in both the older and the non-older adults. What did this translate to in terms of achieving clinical outcomes? Here's shown as the percentage of patients achieving an A1C of less than 7%, and you'll be struck in terms of looking at the hatched lines that older adults achieve goals more readily than younger adults do, and we've seen that in other studies too. So clearly 70 to 80% and 50 to 77% in the dulaglutide and the semaglutide arms of older adults achieved A1C goals. With the same patterns of, in general, greater in Sema versus Dula between the two groups, though comparable here at the higher doses. What about proportions of patients achieving even more stringent goals? Again, same pattern. Older adults tended to better than the non-older adults, and then the similar general pattern of comparisons between the two drugs. Lastly is achieving this goal at any cost of hypoglycemia, and so for that we looked at the triple composite of an A1C of less than 7% without severe or blood glucose confirmed hypoglycemia and without weight gain. And older adults do great. 73% and 83%, 49% and 76% at the low dose and the high dose of sema and dulaglutide. Safety considerations are very important in older adults. I'm going to walk you through this busy table because I think there's a few things to highlight. So number one, in terms of overall AEs, you'll look at the lower dose. It's generally the same between elderly and non-elderly and sema and dula. Where you start seeing a greater number of overall AEs is at the higher dose of either sema or dula at 1 milligrams and 1.5 milligrams. In addition, when we look at premature discontinuation due to AEs, it's a little bit higher at the higher dose of semaglutide at 19%. And if we look at the GI AEs, fairly similar at the lower dose, but it's at the higher dose of either sema or dula where you see a higher percentage of GI AEs of 52%. No other major signals of safety of consideration. So in conclusion, what we see here is that semaglutide was effective and generally well tolerated in both older and non-older patients with type 2 diabetes, and this was not at the cost of hypoglycemia. And I would add that older adults actually do quite well in clinical trials, and there are just general safety considerations when you start pushing the doses.
So does it matter age then?
Age does matter because no, it does matter because I think a very important finding is the high dose effects. in our older patients, you might want to be more worried that they might have more GI tolerability side effects, may not be able to tolerate, and may have more adverse events if you start pushing the high doses. And yet they do a really good job at achieving clinical goals.
Okay, excellent.